first skill that I would like to demonstrate to you is changing a continuous IV infusion to a heparin lock. I will just mention to you that the arm does not need to be on a pillow. It is only here for demonstration purposes. As you can see, the first thing we'd want to do is check the doctor's order, check your critical pathways to ensure that the order has changed to stop the continuous infusion. Then you would want to either turn off your infusion, either by closing the roller clamp, or if the person is on an IV pump, to put the pump on reset or hold. Then you would need to wash your hands or use an antiseptic cleanser per hospital protocol. Always want to make sure that you check the protocol of the facility where you are doing clinical, so you are consistent with the guidelines of nursing practice at that facility. Whenever we attach or manipulate an IV site, we always want to put on clean gloves. This accomplishes two purposes. It is consistent with universal precautions that we protect ourselves from blood and body fluids, and also we want to prevent the spread of nosocomial infection of organisms to the patient, because the IV site is a great access for organisms to enter. So we've stopped our infusion or shut off the pump. We are going to remove any tape that is holding the tubing in place. IV sites come with a lure lock connection, that is that the tubing screws on and has a very tight and secure fitting with the IV site. And what we would do is unscrew to the left and remove the tubing. I know from checking that my patient's chart and from knowing the patient is well hydrated that I do not need to cap this tubing. If you do need to reuse the tubing, then a new sterile cap is applied each time. It is not reused. Now you will see that this site already has an adapter called an anti-reflux adapter, which allows us to not be contaminated with blood backing up, but also allows us to give medications and irrigations. If the site does not, there will be one of two adapters that you might put on. For example, here is this same adapter in the package, and here is a similar adapter with an extension tube. It is very important to note that this must be filled with saline prior to attaching to the patient. For demonstration purposes, I'm going to show you how to fill this adapter. Depending on your clinical site, there are two ways you can do this. One way is with pre-filled syringes, and here is an example of sterile normal saline or sodium chloride 0.9%, which is normal saline. This is sterile coming out of the package, and I would open this. Have a sterile syringe, uncap it, attach my syringe again by a lure lock connection. It would screw to the right to tighten, and I would fill this with saline. Always making sure that saline completely clears whichever adapter you're using. This is especially crucial if you are caring for central lines and need to change the caps of those lines. The next skill that I will show you is flushing an IV site. I would check the IV site This would be done to ensure patency. Typically, the flush to the IV site, if it is a peripheral site, is done every 8 hours to ensure patency. Other types of IV access sites, like PICC lines, central lines, portacaths, have different protocols for flushing. You always need to check the guidelines of your clinical to see if saline alone is the required irrigation or flush, and I will show that to you now. As I've mentioned before, when the site is to be irrigated, there are either pre-filled syringes with sodium chloride, or another very common method is a continuous bag that is kept on the nursing unit. This bag is accessed, it is dated and timed, and is like any other IV solution, only good for 24 hours. I will now demonstrate to you how to retrieve saline from this bag. Again, you will note that this is the same solution. It is 0.9% sodium chloride, or also what we would call normal saline. To retrieve fluid from this bag, you will need to have an alcohol wipe and your syringe. The site gets wiped with alcohol, and then the syringe, attach the syringe. Again, this is a luer lock connection, so it screws in, and you would withdraw the correct amount of saline. In this case, the facility that I'm at uses a 2 cc flush for an infusion lock. We always want to make sure that we express any air, because we do not want to fill with air. We want to fill with saline, and I have my 2 cc's. I would then recap or put back in the plastic container. We don't want to be walking any kind of distance with an uncapped syringe. I would again come to my patient, identify that I have the right patient with the right flush. When I'm near the patient, always use gloves to manipulate any intravenous access. Alcohol wipe the adapter itself. If for some reason you get distracted and turn away, or anything happens, again, re-wipe the site. I would remove my syringe cover cap and irrigate the site. While I'm irrigating the site, I am looking at the insertion and making sure that the site is intact, that there's no inflammation or edema at the site. Again, please check the protocol, because if you have anything other than an infusion lock, the protocol may be that you use a saline infusion or a saline flush followed by a heparin lock flush. This concludes flushing the IV site. I will now demonstrate discontinuation of an IV site. I will now be demonstrating the discontinuation of an IV site. There are many indications for discontinuing an IV site, such as patient's discharge, infiltrated IV site, or other difficulties, routine site change for an IV site. As always, you want to correctly identify your patient and to understand the rationale for every nursing action that you take. I would approach the patient, describe to him or her what I'm going to do, assure them that the intravenous site coming out is much less uncomfortable than the IV site going in. I would wash my hands or use the appropriate cleanser at your clinical site. The other items that you'll need are gauze to hold over the site, tape, and it is much easier to pre-tear your tape so it's ready to go, and clean gloves as well. Before I put on my gloves, I am going to loosen this clear dressing. The advantage of the clear dressing is we can continuously assess the condition of the site, but very difficult to initially loosen with gloves on. Then apply my gloves. I'm going to take the gauze. You can either use a 2x2, 4x3, 4x4. That isn't a crucial. It is crucial, though, that we want to hold pressure at the site as we're removing the infusion lock or the heparin lock. And as you can see, I'm peeling away, but I'm peeling towards the insertion site. So I'm waiting for the actual site where the IV comes in last. As I completely remove the dressing, I am going to hold the gauze at the insertion site and putting pressure, remove. Students often ask me, how long do you hold the site? And my answer is till it stops bleeding. There are many indications for why your patient could bleed longer, such as anticoagulant therapy, low platelet count. So you always want to make sure that the site has stopped bleeding before you release your light pressure or before you tape down a dressing. What I would do in this case is just enclose the IV site in my glove, and then I do have a free hand, once I've assured that bleeding has stopped, to apply the bandage and tape, or a Band-Aid if that's what your facility uses. This is discontinuation of an IV site.